Hello and welcome to today's presentation on coronavirus disease 2019, which is caused by the severe acute respiratory syndrome coronavirus 2. First of all, I would like to dedicate this presentation in honor of all the medical professionals, including the doctors, the nurses, the laboratory technicians, who have lost their lives in line of duty during this pandemic. Your courage and selflessness to serve humanity will be rewarded by the Almighty, inshallah. To the rest of the professionals who are still on the ground in all parts of the world where this infection is still spreading, delivering services, may the Almighty strengthen and guide you as well as protect you. And to the noble doctors, nurses, CRE, and all health professionals in my motherland, Ghana, I salute your hard work in these difficult times. I pray God strengthens you. Finally, it's our responsibility as health professionals to spread awareness and educate the public on this disease and not to spread fear and panic. It's my belief and hope that together we shall be victorious. Now, when we say COVID-19, what do we mean? This is an acute infectious respiratory disease which is caused by infection with the coronavirus subtype SARS-CoV-2, which was first detected in Wuhan, China in December 2019. Now, this virus has been named SARS-CoV-2 and the disease it causes has been named coronavirus 2019, which is abbreviated into COVID-19. On the March 11th, 2020, the World Health Organization characterized COVID-19 as a pandemic. And this is not the first time we've had a pandemic. Actually, we've had pandemics such as the Spanish flu, which occurred in 1918 and 1919, as well as the H1N1 influenza, which also occurred in 2009. Now, these pandemics occur when diseases, such infections affect individuals at an unusual and fast or unexpected rate across the world. Usually, these pandemics have time limits. However, they do not have an area of restriction or they do not have any limited area of occurrence. And the factors which may promote these pandemics include global trade and travel, which we can see in this current pandemic, whereby people are moving from one country to the other, and also factors such as increased infectivity of the pathogen involved in this disease also promotes these pandemics from occurring. Now, this disease is currently spreading worldwide, and it has an incubation period of 2 to 14 days with a mean period of 5.5 days. Now, what it means is that from the point of exposure of these infection to the start of the first symptom is between 2 and 14 days. Now, it is transmitted from human to human primarily through respiratory droplets. Evidence also suggests that airborne transmission is possible, through inhalation of aerolized or aerosolized droplets, nuclei from the sneezing and coughing of infected people. Now, there is also direct contact transmission, especially from hands to face of the infected people. Then also formate transmission, especially with objects and surfaces that may have recently come into contact with infected individuals. Then we also have fecal transmission, Now, evidence suggests that both SARS-CoV-2 and the Middle East Respiratory Syndrome coronavirus are excreted fecally, and so there is the possibility that COVID-19 is also transmitted through the fecal route. Then also we have asymptomatic transmission, whereby people may be carrying the virus, or may be sick but may not manifest any symptom, and so they keep on spreading the virus from one person to the other, even though they are not showing any symptoms. Now, the age group of, or the age group which are affected in this disease is all age, all ages. No one is exempted in this COVID-19. Then, when we look at the overall case fatality rate, it's between 2 to 3.7, and we have more than 1% of the case fatality ratio in people who are 50 years and above, and also more than 10% of case fatality ratio in the people who are aged 80 years and above. Now, the highest case fatalities are found in people who are having, existing comorbidities, such as people with, cardiovascular diseases, and also diabetes mellitus, and specifically hypertensive patients. And I'll explain this very soon. Now, when we look at this diagram, which was provided by the John Hopkins University, as at 27th of March, there were 532,788 cases of COVID-19 and 24,077 deaths worldwide. Now, when we look at this timeline of COVID-19, we realize that this disease started from China, and the cases, the incidents were going up. Japan also started recording cases, as well as South Korea, and other countries were also recording cases. But along the line, something happened. We realized that China was able to slow the spread of its cases, because they managed to block their borders. They were able to restrict the movement of people from one city to the other, and also they were able to avoid mass gathering, as part of the measures they took, and so they were able to halt the spread of the disease. But if you look at the United States of America, which is now topping the chart when it comes to the incidence of COVID-19, it is said that the preparedness wasn't adequate. And if you look at countries such as Italy, Spain, Germany, and France, you could see that the disease became so much spread in these areas, and so Europe became the epicenter of the spread of this coronavirus. Now, moving on, when we look at these territories which confirm case of coronavirus, we see that Russia currently is having this number of cases, and the United States has actually increased up to 105,000 of cases. Then you can see Mexico having 717, Colombia having 539, then Brazil 3,000, Argentina 69. So these are the territories or countries which are having this COVID-19, and my country, Ghana, is having 137, as you can see on the map. Nigeria recording 17. And South Africa seems to top the number of cases in Africa with 1,170 cases. Then we have Spain also having 72,000 and above cases, with France recording 33,000, and Italy 86,000 number of cases, with Ukraine currently having 310 cases present. Yeah, so almost all parts of the globe, India is recording 902 cases, and even Australia is now having 3,143 cases of COVID-19. as well as New Zealand also recording some cases, and also Greenland. Now, let's continue. An important thing that we need to know when we talk about, coronavirus disease is what we call the reproduction number. Now, the reproduction number refers to the indication of the transmissibility or the ability of the virus to spread from one person to the other. That is the average number of infections generated by an infectious person in a totally naive population. And so we have the R naught of coronavirus, to be 2 to 3. Now, R naught more than 1 indicates that the number of infected people are likely to increase, and R naught less than 1 indicates that transmission will likely die out very soon. Like I said, the COVID-19 R naught is 2 to 3, and what this means is that if one person gets infected, he is able to transmit it to 2 to 3 people, leading to a sudden increase in the number of cases. Now, this is what it means. If you look at this diagram, this gentleman over here got the coronavirus and was able to transmit it to these 2 people. These 2 people were also able to, transmit it to 2 people each. And so at the end of the day, you realize that it was only this man who got the infection, but was able to transmit it to almost all of these people over here. Now, this is the burden now, at hand, because the numbers keep increasing. Resources are not available to contain them, such as ICU beds and ventilators are not enough to take care of all these numbers. And this suggests, or this also accounts for the increase in mortality that we are seeing in countries such as Italy. Now, let's look at some case definitions. When we say suspected case, a suspected case is a patient with acute respiratory infection with fever and at least a single sign and symptom of respiratory a disease, that is cough, shortness of breath, and with no other etiology that fully explains the presentation, and a history of travel to or resident in a country or area or territory reporting local transmission of COVID-19 during the 14 days prior to the onset of the symptom of such a person. This is very, very important because there has been cases whereby patients are missed. Patients who had these conditions are missed because they couldn't differentiate between other respiratory tract infections in this case. And so when you find any person with such presentation, the person is a suspect for coronavirus and you must go ahead and test the person. We also have a second definition for a suspected case: a person or a patient with any acute respiratory illness and having come in contact with a confirmed or probable COVID-19 case in the last 14 days period to the onset of the onset of the person's symptoms. And we can also have a patient with severe acute respiratory infection with fever and at least one single sign and symptom of respiratory disease such as cough and shortness of breath, as well as requiring hospitalization with no other etiology that fully explains this clinical presentation. So these are cases that we must suspect and go ahead to perform investigations on them. And what is a probable case? A probable case is a suspected case for whom testing for coronavirus or COVID-19 is non-conclusive as reported by the laboratory. Then a confirmed case is a person with laboratory confirmation of COVID-19 infection, irrespective of the signs and symptoms that the patient is presenting. So once the laboratory investigations says that the person is having COVID-19, don't even wait to see the symptoms that the person presents. Go ahead and start with your management and isolation of this patient. Now, which people are at risk of this infection? Now, although we believe that coronavirus will cause mild treatable symptoms in majority of cases, the elderly and certain people with pre-existing conditions are at higher risk of medical complications in the event that they contract this virus. And so individuals in this high risk group include children and or adults with any of the following conditions. So if you have heart disease, and I've given hypertension as an example, this is because hypertension carries a higher risk of mortality. And the reason is that we are going to see it very soon, but I'll explain it over here. The SARS-CoV-2 virus is believed to have tropism for angiotensin converting enzyme 2 receptors, which are predominantly found in the epithelia of the lungs. Now, these are the receptors which the angiotensin converting enzyme inhibitors, which are drugs that we take or we give to these hypertensives, is these same receptors that they act on, and as such they are more in these hypertensives through a feedback mechanism. Hence the virus easily attaches itself and spread in the lungs. It is based on this that we've recorded increased mortality in patients who are hypertensives as compared to patients who are normal tensives. Also, patients who have severe asthma and or other chronic pulmonary infections are also at risk of developing these diseases and also having complications arising from it. And also in diabetes mellitus and other immunocompromised patients. So we may have such as someone who is morbidly obese with a BMI more than 40. Then we also have pregnancy. Now, pregnant women, we added them not because of any special reason. Because, look, we know that pregnancy, in small proportion of women can alter how, women's body handles severe viral infections. This is something that midwives and obstetricians have known for many years and are used to dealing with it. As yet, as we speaking, there is no evidence that pregnant women who get this infection are at more risk of developing serious complications than healthy individuals. So this was a point to clear out or to clear the air. Now let's look at the structure of this coronavirus to help us understand the pathophysiology of it. Now, when we look at the structure, each SARS-CoV-2 virion is approximately 50 to 200 nanometers in diameter. And like other coronaviruses, SARS-CoV-2 has 4 structural proteins. We have the spike, protein, which is for attachment. Then we also have the E protein, which is the envelope protein that encapsulates the virus. Then we also have the M or the membrane protein, as well as the almighty N or the nucleoside proteins, which holds the RNA, genome. Then we have the S, E, and M proteins coming together to form the viral envelope. And like I've said, if you look at the surface of the virus, we have these spike proteins, which is responsible for allowing the virus to attach to the host cell membrane to help it to enter the host cell, which we are going to see very soon. Then we also have the hemagglutinin esterase dimer. So this is the diagram of the virus. There's a RNA nucleoprotein over here in blue. Then we have the envelope surrounding the virus. Then we have the lipid bilayer also over here. Then the hemagglutinin esterase over here. So basically this is the structure of the virus. And this glycoprotein spikes helps the virus to attach itself to the host cell. Now, with our pathophysiology, this is supposed to be the cytoplasm of the cell. And this is our virus. So our virus is trying to attach, or is going to attach itself to the ACE, or the angiotensin converting enzyme 2 receptors found on the endothelia of the lungs. So the spike glycoproteins attach to these receptors, and through endocytosis, the cell ingests the virus. So now we have the virus inside, the cytoplasm of the cell. Now, the genetic materials, which is single-stranded positive sense RNA, virus, opens into the cytoplasm, as you can see over here, and the host cell ribosomes translate these viral RNA to make proteins such as RD-RP, which is the RNA-dependent RNA polymerase, also known as the replicase. And it is this enzyme, that's the replicase, which is going to read the viral RNA from the 3' end to the 5' end to replicate it. And so at the end of the day, we are going to have more viral genomes, as well as both S, E, and M, proteins of the virus. So as you can see over here, we have more of the genome being, produced over here. And so through exocytosis, before even they exit the cell, they assemble and they form a new viral particles, as you can see over here, viral vesicle over here. So through exocytosis, the virus leaves the cytoplasm and begins to infect other cells of the body. Now, what happens next? Through these processes, which I've just explained, the type 2 pneumocytes, which helps in the production of surfactant in the lungs, are destroyed. And their destruction leads to the release of inflammatory mediators, specifically neutrophils, which causes the macrophages to release cytokines such as the tumor necrotic factor alpha, interleukin 1, interleukin 6, as well as interleukin 8. These cytokines begin to cause microvascular damage, making the vessels become more permeable, and also they become dilated, and so they leak, or fluid begins to leak from these vessels into the alveoli and the lung tissue. And this is what we refer to as the non-cardiogenic pulmonary edema, because there is no cardiac involvement in this process. Now, as we can see in this diagram, you can see that this is the normal part of the alveoli, and this part is filled with fluid. And so you can see that the neutrophils activated the cytokines to remove, or to release the tumor necrotic factor alpha, interleukin 8, 6. Then, as this continues, what happens? The fluid keeps building up inside the alveoli, and this fluid is rich, this plasma fluid, is rich in plasma fluid. This fluid is rich in plasma fluid, right? So what happens is that they begin to denature the surfactant. So the alveolar surfactant gets denatured, and once it denatures, the alveolar begins to collapse. Now, further vasoconstriction takes place. And you see, if you look at the vessel over here, there is further vasoconstriction, as well as occlusion of the pulmonary capillaries by neutrophils over here, as well as platelets and fibrin, which leads to ventilation perfusion mismatch. Hence, we are also going to have decrease in the compliance, as well as an increase in the work of breathing. Before I continue, I would like to say that I have treated acute respiratory distress syndrome in detail in another video, and if you click this blue link over here, it will take you to that video where I took my time to explain everything very well. So you can go there and watch everything in detail. But continuing from here, we have the proliferative phase, whereby there's going to be proliferation of type 2 pneumocytes and fibroblasts, as you can see over here. So we are having a lot of type 2 pneumocytes being proliferated, and hyaline membrane is building up in the alveoli. And these pneumocytes are no more able to produce surfactant, and so the stores of surfactant decreases, leading to hyaline. So once the amount of surfactant decreases, what happens is that the alveolar wall begins to thicken. And this is, partly also due to the deposition of collagen, as you can see over here. So once collagen is also deposited, there's going to be extensive lung scarring. So the lungs now become stiff and they become scarred. What happens? Now, due to these processes that I've just explained, 5 main problems ensues. We are going to have impaired gaseous, diffusion, because the gas cannot pass through the fluid-filled alveoli, into the blood, and so gaseous exchange is going to be impaired. The lung is going to decrease in its compliance, and so the ability for the lungs to expand is going to be impaired. And once this is impaired, it means the patient must use a lot of effort to breathe, which increases the work of breathing. We are also going to have the alveolar collapsing because there is no surfactant. Then, eventually, we are going to have ventilation-perfusion mismatch, which will lead to hypoxia and respiratory failure, and it is this which will kill the patient. Now, what do we do? What do we see on histopathology? Now, on histopathology, examination shows bilateral diffuse alveolar damage with cellular, fibromyxoid exudates, and it's usually bilaterally diffused. Now, we also find that the lung shows evidence of desquamation. As you can see in almost all the pictures over here, there is desquamation of pneumocytes and hyaline membrane formation. And this points us to acute respiratory distress syndrome, as well as pulmonary edema. Now, if you look at the diagram A, we are having focal proteinaceous exudates in the alveolar spaces. If you look at the second diagram, which is B, we are having scattered protein globules, as well as in the third slide, we are having granuloma-like nodules consisting of fibrin, inflammatory cells, and multinucleated giant cells inside the air space over here. And finally, if you look at the last slide, what we see is, as the arrow is pointing over here, we have hyperplastic pneumocytes with, some suspected viral inclusions. And all of these point to acute respiratory distress syndrome as well as pneumonia. Now, how do these patients present? So let's look at the clinical presentation. The most common clinical presentation include fever, which occurs in about 85 to 90% of patients, as well as cough. Then we also have fatigue, sputum production, and shortness of breath. These symptoms occur in almost every patient who presents with COVID-19. Less common symptoms may include myalgia and arthralgia in about 10 to 15% of patients, as well as headaches and sore throats. We also have chills as well as pleuritic pain. Now, in pediatric patients, we have symptoms such as pyrexia, dry cough, sore throats, sneezing, as well as myalgia and lethargy in these children. Some evidence also suggests wheezing in these children, and less than 10% of symptoms which we don't usually see include diarrhea as well as rhinorrhea and also vomiting. Now, how then do we diagnose COVID-19? Now, we diagnose COVID-19 by taking samples of secretions from the patient. We use the swabs obtained using respiratory viral or respiratory virus swab collection kits. Now, in the upper respiratory tract, we take the nasal swab as well as the throat swab. Then in the lower respiratory tract, we take samples from the bronchia as well as the trachea secretions, and also bronchoalveolar lavage. Then also some sputum from these patients. And like I said, there are some shedding of RNA viruses in the stools, and so we take stool sample to also investigate, to see if we will find the virus in it. Now, the investigation of choice is real-time reverse transcriptase polymerase chain reaction, which, according to the recommendations by the World Health Organization, must be repeated every 4 days. Now, when we do PCR, what do we look for? Which genes are we looking for in PCR? The first gene that we look for is the N and E genes, which are associated with beta coronavirus of the bat. And what this means is that these N and E genes are found in bats, and so if they are found in human, it indicates infection of coronavirus. And most importantly, we also look for the RNA dependent RNA polymerase. This is because this is the specific gene for coronavirus. And so when we find this, then we can confirm the diagnosis of coronavirus disease. Now, other laboratory investigations include, the WBC count. Over here, evidence suggests that the white blood cell count vary with, leukopenia, leukocytosis, as well as lymphopenia. However, lymphopenia appears to be most common in most of the laboratory investigations that, has so far been revealed. Then we have increase in aminotransferase levels as well as increase in the lactate dehydrogenase and ferritin levels in patients. Now, which imaging studies do we do or do we undertake in coronavirus disease? Now, basically we use the chest x-ray and CT scans. Now, the chest x-ray, as we know, is cheaper and is easier, but one thing we must know is that it's not sensitive enough. So, what do we find on chest X-ray? We find ground glass opacities, which are shades of gray instead of black, with fine lung markings and vessels, as we see in a loma, lung. Now, an important thing I want you to note over here, even before I say that, we have to, take CT scan. We have to, take patients to take CT scan when we suspect a case of coronavirus, even when their initial chest X-ray showed, negative. It's very, very important. So that's why I'm saying the chest X-ray is not sensitive enough, because there's been instances whereby we took chest X-ray in patients who were positive for coronavirus within the first days of infection or the first initial days of infection, and there were no pulmonary, changes pointing to coronavirus infection, and so it's not sensitive enough. However, if there is high suspicion, you must go and get CT scan. Now, if you look at this chest X-ray, what we find is diffuse micro, nodules which are distributed in both lungs. Particularly look at the periphery of the lung, and also bilaterally. You can see bilaterally, in the middle and lower lung fields, as you can see over here. And also on this chest X-ray, you can see the ground glass opacity is almost everywhere over here. Now, on chest CT, what do? We do a non-contrast chest CT, and it actually gives us a better and a detailed, view about the coronavirus disease. But it's also not specific for coronavirus. This is because the findings that we get are also seen in other conditions such as, acute respiratory distress syndrome and viral pneumonia, as well as influenza. So, what do we see? On chest CT, we also find the same ground glass opacities in the lung peripheries, and they are almost always bilateral. And it may also lead to airspace consolidation in severe cases, as well as the formation of crazy paving patterns, as we see in acute respiratory distress syndrome. We may also find bronchovascular thickening in most chest CTs, as well as some less common findings. So we usually say these are less common findings because they are not typical for coronavirus disease the 19, such as the pleural thickening, the pleural effusion, and the lymphadenopathy. These are less common findings that we find. And so when we look at the chest x-ray over here, you can see the ground glass opacities over here, all over here, as well as the crazy paving patterns all over here. Now, in this CT, you can see there is pleural effusion. All that we are saying is it's not typical finding of coronavirus disease, but it may happen. Research are still ongoing. Then, if you look at the second CT scan over here, we have there's supposed to be a CT of a 75-year-old male with multiple, patchy areas of pure ground glass opacities all over, this place, and you can also see the interlobular thickening, over here. Now, having said this, it is important for us to know that the U.S. Center for Disease, Control does not recommend, the use of X-ray or CT scan to diagnose coronavirus. They suggest that viral testing must be the only specific diagnosing method for this disease. This is because the chest imaging, lack such specificity as well as sensitivity, and they actually overlap a lot of other respiratory tract infections, including influenza, H1N1, SARS, as well as the MERS. And so they do not recommend these imaging studies as the first line of diagnosis. Now, how do we treat these patients? Currently, there is no specific antiviral treatment which is recommended for COVID-19. Infected patients should, however, receive supportive care to help alleviate, their symptoms, and also vital organs must be supported. Now, also, no vaccines have been currently, made, or vaccines are available for, COVID-19. However, investigations are underway, for all these medications to be made available. Nevertheless, we have numerous, antiviral agents and also immunotherapies, which are all being investigated. So currently, avoidance is the principal method of deterrence to help us curb this coronavirus disease. So among these, antiviral agents that we are currently using in the management of the patient include the remdesivir as well as favilavir. These two drugs are polymerase inhibitors, and they are the drugs which are currently being used, in the management of coronavirus 19, across the world. Now, the favilavir is now approved in China to be used. However, the remdesivir is being developed in the USA. However, it's still being used as part of the treatment. Then we have combination of some drugs which are also used in the treatment of these patients. We have hydroxychloroquine and chloroquine plus azithromycin. Now, hydroxychloroquine is an anti-malaria drug, and it's also used in the management of autoimmune conditions such as systemic lupus erythematosus as well as rheumatoid arthritis. Azithromycin is a macrolide, and we combine these two, or these combination, have shown a lot, of efficacy in the management of coronavirus diseases. Now, other drugs which are also being tested include the zinc. Then also we have immunomodulators such as the interleukin 6 inhibitors, which ameliorate severe damage to lung tissue, which is caused by the cytokine release. Then we also have corticosteroids being used, to help reduce the risk of death. So here we use methylprednisolone, very much. In almost all the researches that have been made, they make mention of corticosteroids. Then we also talk about nitric oxide, and this nitric oxide help to reverse pulmonary hypertension, also help to improve severe hypoxia, and may decrease the length of ventilatory support that the patient may require. Now, having said this, we still have patients who may have critical conditions or in whom acute respiratory distress syndrome may be, a complication. And it is believed that almost all patients who are dying because of this major complication. And so, how do we manage acute respiratory distress syndrome in COVID-19? Now, if you look at the link over here, this blue thing, it will take you. If you click on it, it will take you to a separate video where I took my time to explain the management of acute respiratory distress syndrome. So you can click on it and go there and watch it. However, in this tutorial, what we are going to see is we are going to see the aim of management in this patient, and our aim is to improve oxygenation without causing any further damage to the lungs. Now, what do? Immediately we must conduct a rapid sequence induction, make sure the patient is intubated, and 100% oxygen is being delivered to this patient. Also, we must make sure that we try to sedate this patient. Profound sedation is usually required for ventilation in such instances. This is because struggling or coughing by the patient may cause the loss of the recruited lungs that we've made, and this will go ahead to worsen oxygenation. And so we need to sedate these patients. If sedation alone does not help to calm this patient, then we can go ahead and give some muscle relaxants to these patients. Now, the benefit of the ventilation over here is that the ventilation is going to reduce the work of breathing. Also, the oxygen demand is going to be decreased, and eventually these will lead to the correction of acidosis as well as improve cardiovascular stability of the patient. And so, which target do we set for ourselves? We need SpO2 between 88 and 93%, or a partial arterial pressure of oxygen more than 55 millimeters per mercury. Also, the standard tidal volume that we require is 6 to 8 millimeters per kilogram. Why do we require 6 to 8 millimeters per kilogram? Because we don't want to, or we want to minimize alveolar distension as well as volume trauma. The fraction of inspired oxygen must be less than 0.5% in the gas mixture, and this is going to help us minimize oxygen toxicity in these patients. We must also go for PEEP, and PEEP stands for positive end expiratory pressure. This is going to help us keep the lungs open. Now, the PEEP requirement for lung recruitment is 3 to 5 centimeters of water. An important thing that I must stress over here is that higher levels of PEEP should be avoided, as higher levels of PEEP will decrease venous returns and also decrease the cardiac output, which we may not want in our patients. Now, we can also ventilate our patient in the prone position, and evidence suggests that a lot of patients have been ventilated in this prone position, and it's really improved their oxygenation, and this can be done for 12 to 24 hours. Now, we also have another method that we can use for these patients, which is the extracorporeal membrane oxygenation. What we are trying to do here is we are trying to use a pump to oxygenate the blood in the patient. So a pump oxygenator performs gaseous exchange and allows the lungs to do what? To rest. So what happens is that this machine removes deoxygenated blood from the patient, and as the blood passes through the machine, it is purified or it is oxygenated before it goes back to the patient. This allows the patient's lungs to relax or to rest. And once the lungs are resting, it will facilitate healing of the injured lung, and also further prevent the patient from exhaustion or respiratory fatigue in the patient. So it is a very important aspect of the management. However, it's not every patient who requires extracorporeal membrane oxygenation. Now, according to the World Health Organization, the ECMO is indicated in patients who have a high risk of mortality, as well as patients who are having a partial arterial oxygen pressure and fraction of inspired oxygen ratio less than 100. So these are the groups for whom extracorporeal membrane oxygenation is recommended. Now, this is a summary of the management of acute respiratory distress syndrome in COVID-19, and so you can take your time and go through all these. If the patient requires ECMO, what you need to do, and all the things you require is on this diagram. Now, how do we prevent this COVID-19? Like I said, we don't have any things to any medications to prevent these disease from occurring. And so we use the same corona to prevent it from occurring. The C from corona is clean your hands. So what we are advocating over here is you have to regularly, clean your hands after every contact with potentially virus contaminated objects and also infected persons. Let's always wash our hands with soap and water or approved sanitizers if soap and water is not available. The O, okay, so before the O you can see this girl trying to wash the hands over there beautifully. Then the O stands for obviate, which is avoid gatherings. Which gatherings must we avoid? We must avoid crowds of people, public transport, the train stations, airports, and mass events. These are the things that we must avoid. Then also we must try to raise our immunity. How do we do that? We must exercise regularly, try to hydrate ourselves. We must quit smoking. Then we must eat nutritiously. Then we have to try as much as possible to use the tissue, whenever we sneeze or whenever we are coughing, and discard it right after use. Then also if tissues are unavailable and we are coughing or sneezing, we have to cough or sneeze into the crook of our arm, to prevent spreading infections to other people. Now, the second O stands for only sick people or health workers should wear the mask. Then N will stand for no to handshake. Then we have A, to avoid rumors. There are a lot of rumors going around, concerning coronavirus, which is actually not helping with the reducing the incidence of the case. So let's avoid unnecessary rumors. Then finally, we have to always keep a distance between the people that we are talking to. At least we must maintain a 3 to 6 feet distance when we are coughing or we are sneezing near someone, so that we avoid spreading the disease to the person. Now, as you can see, this woman is coughing into the crook of her then these people are exercising to improve or to raise their immunity. Then also we are avoiding handshake as well as avoiding mass gathering. So I think this is all that I have for you. If you need much information concerning COVID-19, you can go or search through these references and you get a lot of information. Thank you very much.